This is More Health, Less Healthcare, and I'm Peter Boland, your host in our seven-part podcast addressing the question, what if they got the incentives right? So let's start by acknowledging there's a version of community health investment that looks generous on the surface, but is paternalistic and ineffective underneath. It's the version where a health system or a foundation or a health plan decides what a community needs, designs a program to address it, deploys that program into the community, and then measures whether the community accepted it. And if they didn't, the program gets labeled as having a community engagement problem. Well, what is it about engagement that faltered and why? And what's the way out of this box? The organizations in this episode did something different. They started by asking. They didn't start by announcing. They started with questions, and they actually changed what they did based on what they heard. That sounds like a low bar, right? Well, in practice, however, it's rare enough to be a genuine differentiator. The examples on our website, bolandhealthcare.com, and in the Health Equity Case Studies book, really run through what the lessons learned are time and time again. I'd like to share a half dozen in this episode. First, Presbyterian Health, and their focus on four operating principles. Their four beliefs as operating principles. Presbyterian Health in Albuquerque, New Mexico, built their community health approach around these four beliefs: health as a shared value, cross-sector collaboration, stronger integration of health services and systems, and the goal of a healthier, more equitable community. And those four beliefs aren't just marketing language. They're operating principles that shape how the organization makes decisions. Health as a shared value means that the health system isn't the sole authority on what constitutes health or how to achieve it. Cross-sector collaboration means genuine partnerships, not vendor relationships, not charity partnerships with organizations that have different expertise, different community relationships, and different accountability structures. And critically, Presbyterian is explicit that community health interventions must be clearly stated, easy to read, and understood by patients and members, not just understood by clinicians, but understood by the people the intervention is actually designed for. And that's a different standard. It requires a different design process, one that involves the community in the design, not just in the reception. They also hold a position that the rest of the industry should adopt universally. Interventions must promote equity to be sustainable, not equity as a box to check, equity as a design requirement. If it doesn't promote equity, it's not going to be sustainable because it doesn't address the underlying conditions that generate the health disparities we're trying to fix in the first place. Again, this is a fundamental tenet found throughout the Health Equity Handbook's proof of concept. Now let's look at Bon Secours working for the community, not just with it. And I want to refocus on Bon Secours again because we spent two episodes noting Bon Secours' housing investment in West Baltimore, and the government philosophy behind that work is one of the most clearly articulated in this series. And it belongs here too. Again, George Clubb, the CEO, is explicit. Bon Secours takes their marching orders directly from the community, not their program officers, not their board, but from the community. It's built into what they call their four ways of being: asset-based, relational, collaborative, and again, that word dutiful. That last word isn't, again, a typical healthcare executive language. It's the language of obligation, of accountability, of a relationship where the community is the client and the health system is the contractor, not the other way around. The distinction between working with a community and working for a community sounds subtle. It isn't. Working with the community means bringing your programs and inviting participation. That's the norm. Working for a community means asking what's needed, then delivering on that. One position the healthcare system as the expert, the other positions the community as the authority. Said another way, the community is the expert, not the hospital, not the health plan, on what the community actually needs. In West Baltimore, that distinction shaped every investment Bon Secours has made in housing, open spaces, early childhood education, and employment. Not because those were, well, the programs Bon Secours came in planning to build, but because those were the things that the community said it needed. Let's also turn to Blue Cross Blue Shield North Carolina and how they've upscaled and upstreamed their program. Blue Cross Blue Shield of North Carolina recognized something that most health plans acknowledge in their annual reports and then don't act on. More than half their population has an unmet need relating to social, economic, and environmental factors. And food insecurity is the most commonly reported. And addressing those needs at scale requires multi-sector partnerships, not just internal programs. Blue Cross Blue Shield North Carolina leaned into social sector partnerships as a core strategy, not as a community benefit, but as a health investment designed to reach underserved communities with upstream interventions and at meaningful scale. They also focused on training underrepresented health professionals to address rural health gaps, recognizing that you can't improve community health if the community doesn't have the providers who look like them and understand their day-to-day lives. This is what looks like when a health plan decides that the community's health is actually their responsibility, not just during the clinical encounter, but upstream in the conditions that determine whether the encounter ever becomes necessary. Now let's look at a very, very different model and a very different solution. It's complementary to what we just talked about. The Hawaii Community Foundation and their trust-based philanthropy as a business model. A very different example, but their trust-based philanthropy is a model that we need to consider throughout philanthropy. The Hawaii Community Foundation offers the most structurally innovative governance model in this entire series, and it deserves more attention than it typically gets in national healthcare conversations. That's because the foundation's, stewards, I use the word stewards here again, more than 1,000 funds. And after their first year of the Change grant-making program, I'll spell out what each of the letters here symbolize change. C is covering community and economy. H is health and wellness. A is for arts and culture. N is the natural environment. And G is government and civics. E is education. They did something most foundations resist. They listened to the feedback they received, they took it seriously, and redesigned their entire approach to grant making and philanthropy based on what they heard. The redesign moved towards multi-year unrestricted funding, meaning nonprofits in each of the islands receive funding that they could use for their actual mission in the way that actually makes sense without being constrained by a program officer's theory of change. The application process was simplified to just 4 questions, not 40, just 4, not 100 pages of narrative, just 4 simple questions. Tell us what you need and why. The result is that nonprofits spend less time now writing grants and more time doing the work. They have the flexibility to respond to what's actually happening in their communities, rather than executing against a program design that was locked in, 18 months ago. And critically, the relationship between funder and grantee shifts from compliance monitoring to genuine partnership. And the cultural preservation dimension of the foundation's work is important to note because health in communities shaped by indigenous culture and immigrant heritage is not separable from cultural identity. And programs that ignore that offer generic health interventions without cultural grounding, tend to fail. And that's really one of the main lessons from the Hawaii community experience. The change framework's inclusion of arts and culture as a health domain reflects a more sophisticated and accurate understanding of what health actually requires. This is a lesson cultural recognition and cultural adaptation we can use throughout the industry. Now let's turn to the University Hospitals in Kansas City and their cultural health navigation program. Again, not the same as a CHW, and we'll explain it in a second. University Hospital in Kansas City made a specific an important investment in cultural health navigation, deploying cultural health navigators who function as a hybrid of medical interpreter and community health worker. It brought the two together. And these navigations bridge cultural and language barriers for immigrant populations. Health patients navigate the entire healthcare system, address social needs, secure insurance and financial aid, and carry the patient's voice back to hospital administrators. And that last function is one worth emphasizing. The cultural health navigator isn't just a service delivery position, it's an intelligence function. When a navigator brings a patient's voice to hospital leadership, the hospital learns something it couldn't have learned from its data systems. What the experience of care actually feels like for the populations supposed to be serving. Another example, Vanderbilt University Medical Center made a similar discovery through a very different mechanism. The Vanderbilt Medical Center and their health literacy screening tool is just 3 standard questions administered to inpatients and outpatients. It revealed that 20% of hospital patients and 10% of primary care patients have low health literacy. And low health literacy is directly associated with lower rates of preventive care, worse disease control, and higher mortality. And that's a significant clinical finding, 20% of patients. And they discovered it by screening, and by treating health literacy as a clinical variable, not assuming that patients who nod when instructions are given actually understand them. That's a critical finding. And again, it shows up in mortality statistics. I want to close with yet a different example of the WIC program in New York City, when first-person data becomes the whole story. So there's one more example, and maybe it's the rawest in the book because it doesn't come with a hospital boardroom or a foundation strategy session. It comes from the waiting room. And again, this is the WIC program as part of the Hospital Corporation in New York City, the Health and Hospitals Corporation. They had a problem that most benefit programs quietly live with. Eligible people weren't using their benefits. Between 2017 and 2019, the drop off from WIC and SNAP enrollment was especially sharp in zip codes with more non-citizens. In some neighborhoods, 30% of eligible women weren't accessing WIC and SNAP benefit at all. So picture Anna. She immigrated from El Salvador, 5 months pregnant, and showed up for her first prenatal appointment. A community health worker sat with her in the waiting room, walked her through the WIC program, even flipped through a pictorial guide of the food product she could get. And Anna didn't know Medicaid even existed, let alone how to apply for it. The CHW helped her book an appointment with hospital counselors just to get the process started. So here's what it actually took for Anna to get WIC benefits and her family. First trip, she goes to the WIC office to schedule her certification appointment because WIC doesn't let you do it by phone. Second trip, she's turned away, missing one document, proof of address, even though she could have been granted 30 days of temporary benefits on the spot. Third trip, her certification appointment finally happens, but the office refuses to enroll her 4-year-old son, incorrectly deciding she can't use the same proof of income for him. The CHW follows up, encourages her, walks her through the program again. Fourth trip, 3 months after she started, Anna finally gets her son enrolled. 3 months, 4 trips, 7 follow-up calls from the CHW just to make sure Anna actually received what she was already entitled to. That's the story. That's what the data showed when CHWs started tracking it systematically. They found 2 major drop-off points in the whole enrollment process, an 86% drop between outreach and eligibility screening, and a 46% drop after referral was made for somebody who was interested and eligible. And when they asked patients why, 4 barriers came up again and again. First, uncertainty about eligibility. 2, and the application process at 35%. The sheer amount of time required to apply, 29% of the time. Fear about what enrollment might mean for immigration status, 22%. And trouble completing the WIC or medical referrals, 14%. What makes this case different isn't that they collected the data, it's what they did with it. CHWs met weekly with WIC staff to surface what patients were actually experiencing. They met quarterly with the state health department to push for policy change. They ran focus groups in English, Spanish, and Haitian Creole that produced real specific recommendations. Let people schedule online, accept the most lenient state rules available, auto-enroll WIC-eligible Medicaid recipients. And one more thing, the data belonged to CHWs and the patients who gave it, not the agencies. That was a deliberate choice, and it's part of why people trusted the process enough to keep showing up. And Anna could have been enrolled in a single visit. Everything just happened after that first trip to bureaucracy. Not eligibility, not need, just plain friction. And the only reason any of it changed is because someone decided to ask why, and then took their answer seriously enough to act on it. So the first person feedback principle, asking real people about their real experience and taking it seriously, runs through all the organizations in this episode. In fact, it runs through all the organizations in the Health Equity Case Studies Handbook. It's how Presbyterian shapes their program, it's how Bon Secours determines their priorities, how community help the Hawaii Community Foundation redesign their grant making. It's how Kansas City navigators inform hospital leadership. It's how Vanderbilt found out that 1/5 of their inhabitants, their patients, couldn't fully understand their discharge instruction. And it's how CHW in New York City waiting room helped pregnant mother get what she was already owed. So in closing, there's no shortcut to community trust. You can't buy it with a donation. You can't manufacture it with a press release. You earn it by showing up, by asking real questions, listening to the answers, and then changing what you do based on what you heard, and then doing it again and again and again. That's the trust factor. The organizations in this episode have different models, different populations, different geographies. What they do share is a genuine orientation towards the community as the authority on what health requires. That's not a soft commitment, it's a structural one. It requires changing who's in the room when decisions get made again. Who's in the room when decisions get made? And that brings us to the final episode in this series of lessons learned and important takeaways. The next episode, once you've asked and you've listened, you have to measure. And once you measure, you have to publish what you find, even when it's uncomfortable. And that's what accountability actually looks like. And we'll take a deeper dive at the next session. This is More Health, Less Healthcare. I'm Peter Boland, and thanks for joining us today.